Hi, my name is Marielle van Goor, Professional Affairs Group Director of Mark Energy. In this webinar I will talk about myopia management and the extended depth of focus design lens Mylo. Myopia has been a current topic for a few years now, but what is the main reason for the onset of myopia? Is it genetics, or rather a set of cultural and lifestyle factors? Let's try to clarify these issues and some others. The number of myopic patients is escalating worldwide, in such a way that we are already talking about myopia as an epidemic. Brian Holden's studies estimated that myopia will affect 5 billion people worldwide by 2050. That will mean a prevalence of 50% of the world's population, when currently it's about 34%. In Asia, Hong Kong, Singapore and Taiwan, already the prevalence is 50% among the young children. That means 1 out of 2 is myopic. The late Brian Holden was champion of ensuring that myopia is on the World Health agenda. High myopia is strongly linked to a higher risk like cataract and retinal detachment. The concerning reality is that 1 out of 2 people will be myopic by 2050 in our part of the world. If we look at what is nearby, the estimated prevalence value in Europe is currently about 20% depending on the area. Also, these values will grow. They will grow to 50, 54, 56 in the next 30 years. If we speak in terms of numbers of people, the data is more shocking. In 2010, roughly 227 million people were myopic in Europe. If the trend of myopia prevalence continues as expected, we might even have 416 million myopic patients in Europe by 2050. Now that we have spoken about the prevalence and the ocular risk of myopia, let's talk a little bit more about myopia itself, which is typically defined as the eye refractive state, in which light comes to focus in front of the retina in absence of accommodation, and meaning to see images nearby clear and far away blurred. Professor Earl Smith from the University of Houston has done some investigation about the question, how does it all works? I quote, "The eyeball grows from the start from the inside of the eye, independently from the nerve system and brain. The retina can actually tell if it's nearsighted or farsighted. The info is transmitted to the pigment epithelium, through the choroid, and finally to the sclera, where it will change the biology of the sclera. In the eyes, there will be a remodeling of intercellular matrix. Enzymes degrade the tissue, and that weakens the sclera and distends the ocular pressure getting higher. So the eye becomes long in myopia." The definition of an optical correction is a slight modification that corrects lines for the purpose of making them appear correct to the eye. The definition for a disease is a change in structure or function that continues to progress over time. It could be an optical correction, it could be a disease, or it could be a combination of these two. And we must realize that it is not just an optical condition, but a disease as well. It's about the retina that's continuing to be stretched as the eye gets bigger and bigger and becomes thinner. The eyes determines whether the myopic or hyperopic and alters the growth and to achieve an optimal refractive area. Changing the focus of the eye can change the way the eye grows. Peripheral refraction can influence the central refractive area and vice versa. When using a divergent lens, ophthalmic or contact lens, to correct the myopic refractive area, the central rays focus on the retina, but the oblique rays passing through the periphery to the lens will focus behind the retina, causing a hyperopic peripheral defocus. Visual signs affecting the periphery of the retina have a strong influence on the growth of the eye. Thanks to the latest studies, we are beginning to understand the cascade between the visual signal and the biochemical signals for eye growth. It seems that the visual sign can alter the biology of the sclera. To minimize the progression, we need the image to be formed on the retina or in front of the retina at all points, and never behind the retina to avoid triggering the cascade. Aberrations are imperfections of the eye that result in light being unable to focus on the retina effectively. There are two types: lower order aberrations and higher order aberrations. The higher order aberrations are responsible for individuals reporting complaints of glare, halos, reduction of contrast sensitivity. Why is keeping myopia low so important? Myopia increases the risk of suffering ocular complications irrespective of the level of myopia. And all of these complications have a potential blinding effect. If you look at the schedule on the right hand side, if you have a low level of myopia compared to emmetropes, the incidence of cataract is twice. If you go over glaucoma and you have a power over -6 diopters, the incidence of getting glaucoma is 14 times higher than an emmetrope. So here you can see that we do have to concern about the kids who have a higher myopia factor. Some factors associated with the onset of myopia are out of our control. Family history. Those with a myopic parent, with one myopic parent, has 3 times more risk developing myopia, while the ones who have 2 myopic parents has 6 times more risk to get myopia. The refractive error is also related to the age. Between 5 and 9 years old, myopia progressed during these childhood years, and the condition to progress until the stabilized at the late adolescence around the age of 27. Studies have indicated that the average refractive error at the age of 7 is close to plus 1.25 diopters. We can determine that a young child with a high hyperopia will be at risk of becoming myopic, while if the same kid is already myopic, there are risks for a high myopia. Geography is also linked. Ethnicity is a risk factor because the highest prevalence of myopia tends to occur in the east and the southeast of Asia, with much lower prevalence in the rest of the world. For example, in 2010, the prevalence of myopia on the average was 28.5% in Western Europe and 47% in East Asia. Currently, we are seeing the prevalence rates of 80 to 90% in the children and young adults in Taiwan and Singapore. Cultural lifestyle factors are fueling the onset of and progression of myopia to alarming levels. Nowadays, we spend less time outdoors, and more time engaging in activities require excessive use of near vision, such as homework and digital device use. Rose et al. Defined in 2008 in the study the amount of outdoor time and near time work in 3 types: low, less than 1.5 hours per day; moderate, between 1.5 and 2 hours per day; and high, more than 2.5 hours per day. The study indicates that when time spent outdoors is high, the risk of developing myopia diminishes. When the time performing near work is low, the risk of developing myopia also diminishes, but not as so much. In essence, the study says the increasing time we spend outdoors has a greater influence on the keeping myopia low than reducing the time we spend doing near work. What is the impact of axial length? The visual system is not well developed until 3 years of age. In general, the axial length increases rapidly in the early stage of life, then slowly increases until the adulthood and then decreases in old age. The increase of power is an average between 6 and 17 years of age. The average length for full-term infants increases from 16.8 to 23.6 mil when they become adults. 1 mm elongation of the axial length without other compensation is equivalent to a myopia shift of -2 or -2.5 diopters. And what about binocular vision? When measuring eyes, it's important to know how the binocular vision is of the patient. In this flowchart, you have some leads to see what device or training will be suitable for the patient. It is atropine, prisms, visual training, pulse, or contact lenses, or a combination of these. Options to manage myopic patients. It all starts with behavioral management. Nowadays, we know that changing some things about the lifestyle can be as useful in diminishing the myopia progression. Some of these rules include spending at least 90 minutes per day outdoors to prevent the onset or progression of myopia, the well-known 20-20-20 rule, limiting near task after school or work to at least 2 hours per day. This is also included the leisure time, handheld devices, reading and drawing. And ensuring the balance between time spending outdoors and indoors at the weekend and increase the exposure of natural light. For us practitioners, we have a toolkit. We can work with bifocal, multifocal spectacle lenses, ortho-K lenses, pharmaceutical agents, and soft multifocal contact lenses. There are some manufacturers who designed optical glasses like Zeiss, Essilor and Hoya. Zeiss with the MyoVision Pro lenses, they have an effective zone in the bottom. Essilor, Myopla, dividing the lens in 2 parts. Within the lower part there will be a power addition. And the Hoya MyoSmart. Basically, they are working with DIMS, Defocus incorporated multiple segments. Another option are pharmaceuticals, like atropine. And atropine is related to the non-accommodative mechanisms. The system will release dopamine, which is an inhibitory chemical mediator for the growth of the eye. The atropine has the effect on the sclera by making the sclera more rigid, so it will not elongate. Options to manage myopic patients, ortho-K. RGP ortho-K can be corrected by -0.75 up to -5 diopters during the daytime. The side effects, like infections, had not been assessed yet, but we do know that there is a demonstration of a rebound effect of the ortho-K efficiency. The first CE marked ortho-K lens is the Minicum Bloom Night and the Minicum Bloom Night Toric. The lens will correct up to -4 diopters of myopia, and the toric will providing additional options for correcting higher levels of the corneal and refractive astigmatism. For the soft lens option, there are 2 lenses who have a CE mark. It's the MySight and the Mylo. Mylo is an extended depth of focus lens that manipulates the higher order spherical aberrations to degrade the overall quality on the retina image behind the retina, while maintaining a good distance, medium and close vision. The global retinal image quality, the GRIC, in single vision, will encourage growth. The global retinal image in single vision lenses will induce the eye growth due to the positive defocus behind the retina. When using extended depth of focus lenses, the grid will blur the images behind the retina and so discourage the eye to grow. The EDOF lens is designed deliberately to manipulate the higher order aberrations to provide a good vision at all viewing distances. And at the same time, the optical design renders the global retinal image quality behind the retina poor. The degradation of the image quality behind the retina acts like a stop signal. The EDOF soft contact lens offers the patient new solutions to their visual needs that monofocal and multifocal lenses cannot offer. I can define the depth of focus as the greatest distance that a view object can be moved from its theoretical position without the blur exceeding the blurring criterion. In other words, you will have an optimal vision over a wide range of distances. In these two pictures, you can understand how we can see a regular contact lens in comparison to an extended depth of focus lens. In a single vision lens, the nearby object is sharp. In the EDOF contact lens, you can see close by, intermediate and far distance very well. The EDOF design can be described to have a non-monatomic, aperiodic refractive power profile across the optic zone from one side to the other side of the contact lens. The advice for wearing myopia management Mylo is start when the growth of the eye is minus 0.50 diopters within a year. Wear the lenses at least 6 days a week. Wear the lens at least 8 hours a day. Wear spectacles when the lenses are cleaned or stored for the day. The 3D optical designs you see over here, you can see the difference of the patterns of the CD and dual focus lenses. They have a monatomic design. The EDOF is a non-monatomic design. Here we have two studies of the EDOF. One is from Jennifer Shah, and the other one is from the Brian Holden Vision Institute, Padmaja Sarakandu. To start with the study of Jennifer Shah. It's a study to compare the visual performance of the soft contact lenses reported to reduce the myopia progression. It's a double-blind randomized crossover trial with non-presbyope myopes wearing MySight CD Pro Clear and 2 prototypes, each for 1 week. Here we see the lens designs that is being tested. The MySight with an add of +2, Pro Clear with an add of +2, the EDOF 1 and the EDOF 2. Looking at the contrast sensitivity, the objective result was that the interaction between the lenses and the distance was significant for both high contrast vision and low contrast vision. MySight was significantly better than the prototypes 1 and 2 for binocular, high contrast and low contrast vision at 6 meters. The overall subjective outcome was the Proto 1 was rated significantly better than the Pro Clear multifocal lens, and both prototypes 1 and 2 were rated significantly better than the MySight, and this is over the clarity and the lack of ghosting and stability, driving vision, lack of halos, overall satisfaction and ocular comfort. the average daily wear time and the average daily acceptable vision time. Participants were the prototypes 1 and 2, and they could wear them each day longer than the average of my sight. They found the vision acceptable and significantly longer wearing the lenses each day. Prototypes 1 and 2 compared to my sight. The eye strain symptoms. Lose concentration when reading or doing close work. And do you feel sleepy when reading or doing close work with these lenses? Prototype 1 and 2 had less issues or difficulties with losing concentration, and the same for feeling sleepy. They had the best results of the test. Conclusions: Prototype 1 and 2 had better subjective visual performance in numerous variables and were better tolerated by myopes compared to the commercial soft contact lens currently suggested for slowing down myopia progression. In summary, this new contact lens design have both potential for myopia control while still maintaining a good visual acuity and a favorable subject acceptance. The patients were divided in 3 groups: a control group with a single vision silicone hydrogel and two groups wearing silicone hydrogel central distance lenses powered an ad of 150 and 250. The other group, children, were divided by group 4 and 3 and 4, and wearing hydrogel contact lenses with a deliberately induced higher order aberration to create the profile that reduced retinal image and the quality for points behind the retina. If we have a look at the 6-month and 12-month tables, we can see that the yellowish-orange color are the lens wearers who wear the lens 6 or more than 7 days a week, and their results was better compared to the ones who had 5 or less days a week. The results of the progression was found between the 2 contact lens test lenses, and at 12 months the percentage of reductions of vision compared to the control lens was by the test lenses 31, 30, 27 and 21%. And for test lens 3, 1, 4 and 2 respectively, the reduction in the change of the axial length was 43, 35, 33 and 30% compared to the control lens. Looking at the result of the high contrast vision, the test lens number 3, the yellow-orange one, is scored the best in the contrast vision. If we look at the performance of the distance, intermediate and near vision, you can see that test lens 4 was out of range in the distance, but the other 2, they were up close to the control lens. And it's the same for the intermediate vision. The intermediate vision, test lens 3, is scoring the same as the control lens. For the near vision, the test lens number 3 is scoring the best out of the multifocal lenses that are presented. The result of the test of the study was that contact lenses that degrade the retinal image quality behind the retinal plane, as well as the contact lenses that impose myopic defocus across a large portion of the retina, can slow the eye down in growth. Significant slowing observed in the compliant wearers and especially versus spectacle wear. Growing evidence that the EDOF contact lenses can successfully slow down myopia. Overall, these results support the use of the novel multifocal type contact lens that slow down the progress of myopia and can confirm previous reports that the support of contact lenses to deliver myopia control. What you can use in your practice is the myopia calculator of Brian Holden Vision Institute. It will help you to let the parents understand and see what the effect is of myopia management. The only thing you have to do is go to the website, the globalmyopiacenter.org calculator, sign yourself in and put it on your desktop. And what you can do, you can choose if you have a Caucasian child or an Asian child. You can put in the years, the age of the child, and the current refractive error. You also can check and list the myopic management option. I chose here for a multifocal soft contact lens. And here you can see, if you do nothing from now, the age of 10 minus 1, you will end up probably around minus 2.13 diopters to minus 3.25 diopters when the kid is 17. If we start out with a myopia management lens, we can reduce the growth of the power with 49%. And the kid will have maybe only, at the highest, a minus 2. This will have a huge effect on the life of a kid and an understanding of the parent. Myopia management can bring you a lot of tools to help the patient. And one thing is for sure, better act than doing nothing. Using the Mylo extended depth of focus soft contact lens will help you to slow down the progression of myopia.